It's a long video, so let me cut to the chase. We are continuing our discussion of Abigail Shrier's Bad Therapy. We are working through a section of the chapter, A Crisis in the Era of Therapy. This section is on the Treatment-Prevalence Paradox. Don't worry, by the time this video is over, you'll know what that paradox is and be able to impress your friends at the local trivia night should the topic of mental health care spending in the US for the past couple decades come up. This video made possible thanks to the continuing support of viewers, patrons, and PayPal pals like you. Thanks! Just so you're aware, got cat combo in the cubes right now. I know some of you like when I dig into the sources. Y'all are in luck with this video. Between me and Shrier, there's 54 references. In any event, I'm eager to get this train moving, so we're gonna speedrun this intro. I'm Cass, the cognitive psychologist, and I've made it part of my life's work to use those skills to critically analyze pop science books. And one way we can separate the field of psychology is by its squishiness. Counseling psychology, and on many regards, clinical psychology, are squishy. These are largely concerned with how people feel. Well, how they think can come into it. It's more about their sense of their feelings and thoughts and squishiness, you know? The experimental branches of psych, including cognitive, aren't squishy. Feelings might come up in some of the research questions being asked, but that's not really our focus. We're interested in how people think, learn, remember, operate in groups, stuff that isn't very squishy, huggy, feely like it is in counseling and clinical. So I do not have training in therapy or psych disorders. I do have some lived experience because, and I've been dealing with it for decades, so that's about it. I can, however, read and distill down a body of literature and get to the gist, and also critically analyze arguments being sold to me. If you like the cut of my jib, support the work I'm doing. Subscribe, become a channel member or patron. And if you subscribe to the higher, fancier tiers of patronage, you'll get a thank you card from me every month, in addition to a sticker. Just random sticker. And oh look, other stickers that are available on my merch store at Fourth Wall, in addition to mugs, hoodies that I'm not wearing in this shot, t-shirts, what have you. Finally, the visual cues I use to indicate where ideas are coming from. This means I'm paraphrasing the book. This means I'm responding to the book or integrating my thoughts with science. So much science in this video. And data of what money is going where for healthcare and social security spending. Life can be weird sometimes, the paths you're taking down. We're staying at this angle, kinda, because while I was changing sweaters, Cats knocked one of the lights over into the camera and so we spent like an hour and a half trying to get it back to where it was, and this is the closest it is. We're gonna stay at this approximation of the angle because briefly, my body's going through it. Some skin stuff, some nerve stuff, and it's just a lot. And with us firmly planted here, ready for the science, let us commence. Content advisory. Just a heads up that for a portion of this video, at the timestamp on screen, we will be discussing suicide statistics. It's at a pretty impersonal level that's mostly about rates and trends, but we do spend a little time on why those rates might be going up. If that is something you want to avoid, I'll warn you when we get there and give you the timestamp again to skip it. There's also a brief one-sentence mention of healthcare spending allocated to treating self-harm. The Treatment-Prevalence Paradox. Shrier starts this chapter with a little bit of squishy psych history, as covered in the book In Therapy We Trust, America's Obsession with Self-Fulfillment. Main point. The author argues that the current American youth mental health problem started with the soldiers coming back from World War II, and Congress responding by, quote, a dramatic expansion in preventative therapeutic services, meaning therapy was aimed at the, quote, healthy. Eva Moskowitz, I'm not sure, tries to explain the history, as of 2001, behind the, quote, therapeutic gospel that's taken over the US, in her opinion. If you're in the New York City area, you might already be familiar with her work. Apparently, she opened the first Success Academy charter school in Harlem, is an advocate for charter schools as tools for social justice, and interviewed to be Trump's Department of Education secretary the first time around. There's so many rabbit holes here, and all are tangential to what we need to cover. So just, if you're curious, links will be in the description box, and yeah, have at, especially for this stuff with the Success Academy. Pretty interesting reading. The chapters of Moskowitz's book Shrier focused on are 4 and 5, which are on the world wars and the post-war home front. Moskowitz argues that all sorts of mental health professionals were created to help grease the American war machine's gears, and with the war concluded, they shifted their focus to the women back home. She asserts that women's magazines helped lay the groundwork for the shift to financially pan out. Just to make this clear, Moskowitz is assuming a sort of malevolent, capitalistic intent here on the part of the mental health practitioner community. That they didn't have to come back home with an improved understanding of how people tick, especially your average person, and push for the formation of agencies like the National Institute for Mental Health. They chose to because it was a huge, untapped market that they could profit off of. In many ways, this book is an antecedent to Shrier's Bad Therapy. Has the same therapy bad stance, albeit from a more liberal social justice perspective. Similar to what would be my brief review for Shrier's Bad Therapy, reviewers of Moskowitz's book say that it has some interesting ideas to think about if you zoom out far enough, that maybe therapy isn't something we should think of as being necessary for everybody, but it trips over itself in the details. In a review in the Journal of the American Medical Association, the author notes the many important questions that pop up, but go unanswered. The Bulletin of the History of Medicine review calls out the relative shallowness of what's covered, and that, quote, "The book is basically a demolition job. One would never guess from this account that anyone has ever benefited from psychotherapy or psychological concepts." From the 1940s to 1990s, there was a rapid expansion in the number of mental health professionals, as well as money spent on these services. Before we get into the references, I want to emphasize a tricky detail here. Something I'm not sure Shrier's doing intentionally or not. The 1940s to 60s claim is for the number of members of the American Psychological Association, or the APA for short, whereas the 70s to 90s is for the broader mental health professional umbrella. This is a Venn diagram situation. The APA is a professional organization centered on psychologists. Some psychologists in it will be mental health practitioners, but it's not restricted to that. Looking at this from the other direction, some mental health practitioners will be members of the APA, but not all of them, because this also includes psychiatrists, social workers, psychiatric nurses, to name a few. Basically, there's a fundamental problem with how Shrier is setting up this comparison. APA membership does not give an accurate idea of how many squishy psychologists are out there in the mental health trenches with the other mental health professionals. Moskowitz's book is Shrier's support for the early chunk of the APA membership numbers, but these figures are unsupported in that text. Cool. Love it. Turning to the APA website itself, there's a little bit on its history that includes membership counts, but with different starting and ending points, so I can't truly compare them. Seeing as how no one is sharing where these counts are coming from, it is what it is. However, keep in mind this is for the APA. This growth would also include increases from cognitive, social, human factors, and other disciplines that exploded in the wake of World War II. Attributing that solely to counseling and clinical psychology is just wrong. Endnote 23 is attached to the claim that the, quote, number of mental health professionals quadrupled again from 1970 to 1995. This comes from Frank Ferretti's 2004 book, Therapy Culture: Cultivating Vulnerability in an Uncertain Age. This is the second book of Ferretti Shrier has cited this chapter. The first was about how paranoid parenting was screwing up millennials, so parents needed to stop listening to experts on the matter. Going to the page Shrier's point is to, we can see her claim almost verbatim, and a reference. Piecing things together, because why have an easy-to-use reference section in your book, right? This claim support is attached to the 2002 book, Creating Mental Illness by Alan Horowitz. Setting aside the problems with this book, we follow Ferretti's breadcrumbs to this book's page 4. Again, the claim of quadruple mental health professionals between 70 and 95, and finally, the trail ends at the Center for Mental Health Services. These pubs are statistical reviews of managed mental health care as published in 1996 and 1998 by the U.S. Department of Health and Human Services. Now for the plot twist. I don't know where Horowitz is getting quadrupled from. Looking at the data for the number of full-time equivalent staff in all mental health organizations, a problem pops out. They aren't including data from 1970 or 1995. The earliest these tables go is 1972, and the latest is 1994. That's weird, Horowitz. Since these tables are basically the same except for the 1994 column, we'll focus on that one. Nowhere on here was there a fourfold increase between 1972 and 94. The largest increase was threefold in the number of other mental health professionals, but that's it. If we go into specific treatment center types, we do see increases of the magnitude everyone here has been talking about. This is for emotionally disturbed children, and some staff disciplines do grow that much, like all patient care staff. But given the general trend from the first table, other areas saw decreases, such as in state and county mental hospitals. Most categories of staff shrink, sometimes substantially. This is largely due to the deinstitutionalization movement that happened when these sorts of facilities were widely closed down. This is discussed in the report section on mental health services in jail, as those have become the access point for many people who previously would have been treated in the now closed facilities. Altogether, what does this mean for her explosive growth claims? Aside from the APA membership growth between the 40s and 70s, the story doesn't seem to be what Shrier and her sources have said. The increase in patient care staff, which encompasses all people doing some form of mental health care work and not things supportive of that, wasn't even double. Yes, the number of people doing this work has grown, as has our understanding and cultural importance on mental health. This shouldn't be attributed to some big therapy conspiracy, as Shrier and all of her sources have argued. Last claim of this paragraph is the doubling on mental health spending every decade since 1986 in the US. Her reference is to a Statista plot published by the Statista Research Department in 2014. Year is along the vertical axis, and total expenditure for mental health services are along the horizontal in billions of dollars. An important thing to take notice of is the weird spacing of years. From 1986 to 2000, it's every other year. 01 to 05 is every year. There's a gap until 2009, then it's every year. However, starting in 2010, the values are projections, not actual recorded values. The sidebar says the plot was, quote, assembled from several SAMHSA reports. SAMHSA being the Substance Abuse and Mental Health Services Administration. Signing in and trying the source links reveals it's a dead link. Thankfully, I managed to stumble across one of the source reports. Maybe I've just been unlucky in my search terms, but finding data on the mental health expenditures has been tricky. There's the 2014, SAMHSA report with the projections. There's a Federal Reserve Bank in St. Louis that has drastically different numbers, like lower across the board, and a whole bunch of articles talking about the economic costs of mental health, like how much money hasn't been produced in the economy because people are out with depression or whatever. The SAMHSA table also doesn't match the expenditures in the Center for Mental Health Services, so I really don't fucking know at this point. It's a mess. If you are able to point me in the direction of the mental health expenditures in the US over time, drop it in a comment and I will update this because as it stands, I'm not finding it. So we are going to move forward with the SAMHSA projections. Shrier's claim is that mental health spending has doubled every decade since 1986. In this table, it's not quite doubled to 1996, and then there's no data for 2006. Given the change from 2005 to 2009, it's reasonable to assume that 123.8 would be in there, so okay, fine. However, the projection for 2016 falls pretty short of the 248-ish billion of Shrier's claim. The projection for 2020 doesn't even reach that, so this claim, just on its face, is blowing the growth out of proportion. Given the subtext of Shrier including this, which I'm reading is following along the book's vibe of big therapy having convinced people they're worse off than they actually are, and is particularly hitting the youth, I think it's worth probing what's going on with this growth a bit more. At least as much as I can, given my difficulty in finding definitive mental health expenditures. One way we can contextualize this is to see how it fits in the total health spending. The data from the next plot was pulled from the Centers for Medicare and Medicaid Services historical data. I matched the formatting from Shrier's Statistisource. Expenditures along the x-axis in billions of dollars, and year is along the y. The blue bars are the statista values, with the lighter blue denoting the projected values. Green bars represent the reported total expenditures as found in the CMMS historical data for a similar time frame. The broader healthcare spending seems to drastically outpace the mental health portion, especially in the last 10 years plotted. While mental healthcare expenditures didn't double every decade since 1986, though total healthcare spending sure did, at least from 86 to 96 and 96 to 06. Stick a pin in how to feel about that. We'll come back to it after discussing some considerations. One thing we can think about is how the different categories of treatment have changed. Total healthcare spending has grown, but that doesn't mean the different treatment types have grown proportionally to each other. Shrier seems to be implying that mental health spending has ballooned compared to the rest. Is that the case? To answer this question, we're going to be jumping back and forth between two papers with the same lead author. The older paper is focused on teasing out the factors associated with the growth in spending and contains data up through 2013. And the newer paper picks through the data through 2016 to see how different conditions have been impacted, like how spending has changed in the different conditions. In 2016, for mental and behavioral disorders, which is their catch-all bin for all psych issues, the total spent was $180.7 billion US dollars of the $2.7 trillion total spent on US healthcare. Other categories with similar costs were neurological disorders at $173.9 billion and general wellness care with $167 billion. Now, comparing the rate of change from 1996 to 2016, the psych bin experienced similar growth to most other categories, with a 2.7% total change per person's annual expenditure. The musculoskeletal disorders experienced a slightly higher rate of change, while digestive and cardiovascular diseases saw less. And I'll point out the average rate of change was 2.6%. However, if we look through the specific conditions on this table, that change within psych disorders wasn't uniform. As a note, the rank column denotes the different conditions' rank in total spending. So for example, rheumatoid arthritis ranked 26th highest in overall spending, but it's top of the list here because it had the highest change in spending between 1996 and 2016. The top psych disorder by change is ADHD, sitting with 6.6% growth from 1996 and ranks 42nd among spending by condition. The next psych group are the anxiety disorders, with 6.2% growth and being 21st overall. A ways down, we've got bipolar at 2.9% growth and 48th overall. Continuing on, there's depressive disorders with some growth at 2.3% and being the 13th highest in total spending. The last of the psych disorders on this top 100 table is schizophrenia, which actually saw a decrease in the rate of change, negative 1.1%, and sits just behind bipolar in the rankings. While we're looking at this table, I'll mention that counseling services is categorized into well care, is ranked 101st in the spending rank with $2 billion spent in 2016. Like, it's at the top of this least expensive conditions table. Okay, so spending on mental health overall seems to be right in the middle of the category pack, even if some conditions like ADHD and anxiety experienced more growth. What is driving this change? To answer that, we turn to the older of the two papers and check out the factors behind the spending increase. This figure shows the 10 conditions associated with the highest absolute change between 1996 and 2013. The depressive disorders umbrella was 5th. The spending change for depressive disorders was $30.83 billion, with the older amount adjusted for inflation. This means there was a 3.4% change. Looking up at the average change for all conditions and causes, we can see this is actually slightly below the 3.52% overall. The types of care that seem to be driving this change are expansion in medications and emergency care, at 6.84% and 7.02% respectively. Outpatient care had moderate growth, 3.62%, nursing facility care more mild, not quite 1%, and inpatient care actually shrank, negative 1.32%. The age bracket with the most growth was the adult group, ranging from 20 to 64 years old at 3.68%. The younger and older groups had less of a change. The authors broke the data down by 5 factors typically attributed as driving the spending change: population size, age, disease prevalence or incidence, service utilization, and service price and intensity. Intensity in this context is sort of how many things they're trying to do in one visit. So if they know they only have you for an afternoon, but they need to run a bunch of tests, they're going to be running them, and it's going to be a more expensive visit because all of that shit's getting done. And also, visits are just more expensive. Overall, since 1996, the factor associated with the most change is the service price and intensity. This means, on average, a trip to the doctor or a prescription fill is more expensive in 2013. Recall that they're adjusted for inflation, so it's not just the 1996 buck just isn't buying as much. The size and age of the population are somewhat driving this change, but not nearly as much as service price and intensity. Interestingly, the prevalence or incidence of disease and service utilization shrink. But these changes weren't uniform across the different types of care or conditions. The next plot we're going to look at is going to look like a lot, because it is. But don't worry, we're going to work through it, you'll be able to read it. And we are again going to focus in on the depressive disorders category, because that's what we're talking about. Similar to the last plot, the monetary change is along the horizontal axis. The type of care is the vertical axis, and the color of the bar is for the change factor. If you're not familiar with the term, you can think of ambulatory care as appointments you're expected to walk in and out of on the same day. You ambulate, so it's outpatient stuff. As plotted here, ambulatory or outpatient care and prescriptions were associated with the highest financial growth. Within ambulatory care, cost per visit has the largest share of change, followed by population size and service utilization. On the medication front, more people utilizing this form of treatment drove most of that change. But it wasn't all growth. Significantly less people are using inpatient care, but those visits that do happen are more expensive. This older paper includes a beefy supplemental PDF, a huge chunk of it being those plots that we just looked at for the depressive disorders with the types of care and factors of growth for 150 conditions, including those psych disorders we talked about in the newer paper. We're back to the previous figure because the format changes a bit in the supplemental materials. So we're going to get oriented with depression, then we're going to look at the psych-relevant conditions. Instead of stacking the bars into the type of care bin, this has them as separate dots with error bar whiskers. It's not as aesthetically pleasing as the stacked bars, but it is ultimately more informative. In the newer paper, ADHD was the top of psych disorders in proportional change instead of absolute change, which is what this paper is using. Assuming there wasn't a drastic shakeup between 2013 and 2016, this change seems to have been a result of more outpatient care and prescriptions, similar to depression. The story within those care types is remarkably different. In outpatient care, the strongest factor for ADHD is service utilization, followed by population size and service price, whereas service price was the strongest factor for depression. In prescriptions, cost was the largest factor for ADHD, followed by population size and utilization. In the newer paper, the second psych disorder in proportional change was anxiety. The change here was also largely driven by outpatient and prescriptions, with the factor patterns somewhere between ADHD and depression. More people using outpatient care was the highest factor of change for that treatment type, followed by more people having anxiety and it being more expensive per visit. More people were also using prescriptions, although they're slightly more expensive too. The emergency department treatment type saw more growth for anxiety than depression, with the cost per visit being the strongest factor in change. So, the answer for what's driving this increased spending is a relatively convoluted mess, at least when you dig down into the specific disorders or conditions. By and large, it seems to be more people using outpatient care and prescriptions, and the cost of those growing. Zooming back out to the whole population, is the US drastically different from other countries in health and mental health spending? Aside from the glaringly obvious difference, that is. Our long-suffering northern neighbors spend a little over 6% of their total healthcare spending on mental health care, a figure the Canadian Mental Health Association calls inadequate. And that's before wrapping in how uneven access is to mental health care across the country. For whatever it's worth, the US mental health portion was 6.7%. So hey, even though our system can bankrupt you, we're not doing worse than Canada proportionally in this regard. Yay. The Canadian Mental Health Association report I cited points to France's as high as 15% mental health spending as something Canada should be aiming towards. Amusingly, A paper critically looking at France's mental health care system points to Netherlands as the system they should be emulating. Regardless, many countries in the EU devote at least 10% of their total healthcare spending on mental health, something that's apparently inconceivable in this quadrant of the world. So yeah, the US is different from other countries in how much is being spent on all healthcare as well as mental health. In the bad, we're fucking up and dropping the ball kind of way. But we know who Shrier's really concerned with here. So what about children? How much money is being spent on the children? Won't someone please think of the children? The similar changes in healthcare spending papers to what we've been looking at, which also has considerable overlap in the author pool, focuses on the spending in children's healthcare up through 2013. Of the $233.5 billion USD spent on children's healthcare in 2013, $37.1 billion goes to mental and substance use disorders, which works out to roughly 15%. As shown in this figure, the majority is spent in outpatient settings, followed by prescriptions, inpatient facilities, and a sliver in emergency departments. Altogether, this category contributed to 24.8% of the spending growth from 1996. Of this, the largest growth came from ADHD medication spending in 5 to 14-year-old boys. It is noted that, quote, this aligns with past research that indicated a growth in diagnostics and treatments of ADHD among this age group since the early 2000s. These findings call for greater research on increased costs associated with ADHD care, effectiveness of ADHD interventions, and cost-effective strategies for children with ADHD. A couple other psych disorders show up in the top 20 conditions by amount spent. $5 billion were spent on depressive disorders in youths, with the majority being spent in outpatient care, roughly a quarter in inpatient care, and the rest on medications. Rounding out this table of the 20 most spent conditions is anxiety at $3.4 billion. This was largely in outpatient care, and smaller subsets in inpatient or medication. Keep in mind these authors have tended to lump counseling as its own separate thing from the treatment types and conditions. So it's most likely these figures that we're talking about for the kids spending isn't including therapy. ADHD spending is the largest growing condition since 1996, but it's not the only psych-related one in the top 10. The other diagnosis pertinent to our discussion is autism. The change per child financially isn't large, but in terms of percentage is much higher, sitting at roughly 21% since 1996. While some of this can probably be attributed to a better understanding of the disorder, so more kids are being diagnosed, although that seems to have potentially plateaued now, we can't forget that costs associated with all aspects of care have gone up. But let's return to the big picture with the most recent paper on total healthcare spending. If we look at the different age groups, the under 20s makes up roughly 11% of the total healthcare spending, despite being about a quarter of the population. The age group with the highest spending for mental and behavioral disorders are the adults, accounting for almost 72% of the spending in this category. Youths are roughly 15%. Going through the largest spending conditions again, youths get 10% of the spending for depressive disorders and 9.7% for anxiety disorders. Down in ADHD, youths take the majority spent with 58.2%. But adults are back to the majority for bipolar and schizophrenia. Thankfully, those poor kids. Way down in the 93rd spendliest category, youths take the majority again in autistic spectrum disorders at roughly 73%. While we're down here, I'll add that over 80% of the spending for self-harm is in adults. Youths make up 9.4% of the spending here. So a proportionally small but day-to-day eye-watering amount of money is spent on the youth's mental and emotional health. The youth spending paper mentioned that psych categories with the increased spending are things that will continue to affect the adult population when they grow up, so, paraphrased, it's not like this money is being fruitlessly pissed away. Let's summarize all the questions and considerations to work back to Shrier's argument. Mental health, suddenly cat. Mental health spending doesn't seem to have grown disproportionately to the rest of the healthcare spending in the US. If anything, it seems to have stagnated. But part of this could be due to a combo of many psychiatric drugs coming out of patent protection, thereby opening the way for generics, and what's called a dry drug pipeline, meaning there's no new drugs expected to enter the market. That said, having this all plotted out really brings the scary growth in health expenditures in this country into crystal clear focus. The clusterfuck that is the US medical system is just freebirding its way into making this dystopia we call home that extra little bit worse. The rising costs can be chalked up to many factors, including rising costs of healthcare visits and medications. The US is actually behind many common comparison countries in the EU for how much is spent proportionally on mental health and illness. While spending on the youths may have increased, particularly for boys with ADHD, by and large, it's not out of step with the rest of healthcare spending. So all of that is to say that what seems to be the subtext here from Shrier is wrong. Big therapy has not spun up a fraudulent industry preying upon the mentally healthy, whatever that would actually mean in this context. Among the consequences of World War II, a field of practitioners deciding they needed to invent a market doesn't seem to have been one of them. APA membership is not an accurate representation of mental health workers. The number of mental health professionals has not quadrupled in Shrier's time frame. And while spending, or at least projections of spending on mental health, hasn't fully doubled as per Shrier's claim, the increases in spending cannot be chalked up to more mental health practitioners floating around, inventing work for themselves. No. I just want to draw your attention back to the bullshit asymmetry principle for a sec. In Shrier's book, all that was a couple sentences. I spent days upon days upon days digging through all the books, papers, and governmental references, chasing down and thinking through these claims. My results are another check in the Nope column for this book and shared on this rather obscure YouTube channel. Hers is a bestseller. Quote, "There's a paradox embedded in this tale of exponential expansion. More widely available treatment ought to abate the rate and severity of disease." Then she quickly lists off breast cancer, maternal mortality, toothlessness, and childhood mortality as having improved as a result of better treatment. Maybe she's being hyperbolic, but nothing she's presented has been exponential. Being pedantic is part of my brand, but words have meanings, especially mathematical words like exponential. It's the darndest thing, though. She had all those references for the opening paragraphs, but none for this one. We're not going to spend as much time here. 40,000 deaths, 1989. These are some rather specific numbers. Too bad she gives no indication where she found them. Deaths from cancer have been slightly dropping despite incidence rates increasing. However, in a repeating theme for this paragraph, these are rates on average. White women fare the best here. Mortality rates haven't changed since 1990 for Indigenous women, and despite proportionally being less likely to develop breast cancer, Black women are significantly less likely to survive. And pedantic, I don't know if I'd call the fall in mortality rates, quote, plummeting. I'm not sure why she zeroed in on antibiotics for maternal mortality. That certainly was part of the story, at least. The figure on screen is from a 2021 paper placing the US maternal mortality rate in a historical and global context. This shows the US maternal mortality ratio from 1935 to 2018, according to a couple info sources, for different racial groups. 1987 was the low point, but it's been on a bit of a rebound since. The authors list a couple reasons for the historical improvement: shifting to hospital births in the 1940s, implementation of antibiotics in the 50s, Medicaid in the 60s, improving accessibility to care. So sure, Shrier, antibiotics are part of the drop. However, this drop has been more significant for white women. Also, Shrier, antibiotics are not going to help with many causes of death, like postpartum hemorrhage, eclampsia, or an embolism. Currently, the US has the highest maternal death rate among developed countries, with Black women having a drastically higher rate. I had more trouble finding statistics for dental stuff, maybe in part because this form of health insurance is far less likely in the US. The total rates of edentia, which is apparently what it's called, have gone down in the US, but again, there are differences based on race and socioeconomic status. However, the rates of people without some form of dental coverage is still way too high, so it's unclear what this will do to rates of total edentia down the road. Can I also throw in how oddly specific this is? Focusing on people not having any teeth instead of dental issues, given the complex and important relationship between oral health and systemic disease. Weird. And then this last sentence. Context, Shrier has spoken kindly about RFK Jr., so I guess she's just going to overlook the disastrous effect he could have on those childhood vaccine gains she's boasting. Now, finally, the point of this section. Quote, "And yet, As treatments for anxiety and depression have become more sophisticated and more readily available, adolescent anxiety and depression have ballooned. The basic gist here is that, quote, more treatment has not resulted in less depression. And she's citing a 2022 paper called More Treatment But No Less Depression, the Treatment-Prevalence Paradox. And she spoke to some of the authors who told her this was probably also true for anxiety. Quote, and while the authors admit there was likely more depression in the past than we realized, they argue that there is at least as much, and probably more, depression now. Endnote 28 contains Shrier's comment that these papers are looking at point prevalence, not lifetime prevalence, so will only include recent depression events. Why Shrier seems to think that they would have been able to tease out the, quote, psychiatric gains of the last 20 years if only they had used lifetime prevalence instead is beyond me. In any event, a paper we'll discuss soon does a good job talking about a somewhat similar concept: incidence versus prevalence. Basically, incidence is taking note of new depression peeps when they pop up, while prevalence reflects the overall population likelihood of the disorder. The treatment-prevalent paradox is roughly as she's described, with an important distinction she's missing. It is the treatment-prevalence paradox because treatment follows people developing the disorder. People generally don't seek treatment before they're depressed, right? Once they develop depression, they are having an incident of depression. This is their incidence of depression. Now, with depression, they may seek out treatment, and hypothetically, if the treatment is super duper effective, they may not develop depression again, thereby reducing their impact on the population prevalence of depression. How many people in the population currently have depression? The sticking point I'm seeing in Shrier's references plus other things I dug up is that we've conceptualized all depression as if it will recur. Thing is, there's good reason to believe it'd be better to think of depression as having two pathways. Those who will have a single depressive event, and those who will have depressive events again and again. Problem is that this is a relatively new idea, surprisingly. So the research hasn't been designed to separate people into these two groups. Consequently, we can't say what will push somebody into having recurring depressive episodes, or what resilience factors the one-offers had or developed and is preventing them from kicking back into clinical sad times. Another complication is that rushing in to treat the one-offers might inhibit their natural responses to the depressive event, which then could impede their ability to cope in the future, thus making it more likely they have recurring depression. Furthermore, since pharmacological and therapeutic treatments take a bit to build up to their effectiveness, the one-offers might be done and dusted with their depression before those treatments even have a chance to work. All of these papers emphasize we need to take depression seriously, and treatments need to be available and offered to those who need them. The important thing now, in light of the treatment prevalence paradox, is to figure out these two pathways. Are there indicators which pathway somebody will potentially go down? And also, if we can figure that out, to sort of leave the one-offers alone, let them have their natural response to the depression and develop their resiliency, and make sure that the people who will have recurring depression get the treatment they need, and quite possibly therapy that builds up the sort of natural response the one-offers have, so they're more resilient in the future and maybe won't have recurrent depression, or at least it won't be so bad. Given the difficulty in finding the treatment approach that will work for many people, it also seems like we need to get a handle on the different root causes of depression. Heck, we can even spin this in a way the insurance companies will like. If we could do a genetic test to figure out which is the best antidepressant option for somebody with depression, we can get them on the appropriate medication faster instead of having them bop through a bunch of different medications, using the already stretched thin resources of healthcare providers and everything else less, and sending them on their way faster. So there's less visits, less medication time lost and costs, and yeah, they're just hopefully treated on their depression pretty fast. It's a win for everybody. But this isn't just about the probable two paths of depression. Another issue to consider for the treatment prevalence paradox is that the treatments aren't readily available universally. You're more likely to get the full treatment offering if you're living in a major city and are of sufficiently high socioeconomic status. If you're not both those things, or worse, neither of those, you're not going to get maximal treatment. If you aren't getting treatment, is it really fair to say that it's the treatments failing you? This fits back in with some of what we saw for medical spending, and even some of the medical successes Shrier was touting. These are more likely to be true if you're white, educated, and living in a large city. Pertinent to Shrier's entire argument, though, the majority of these papers agree that the rates of depression are increasing, especially in the last decade. Why would that be? Some of it can be attributed as fallout from the pandemic, but it was on the rise before that. Izawa and others note that the increases were most pronounced in youths to young adults and women. They speculate some of it could be social media serving up content that could feed into a depressive episode. But increases have been stronger in southern, rural areas of the US that were already struggling with substance use and poverty. The same seems to be true in Australia and Germany, among other countries, I'm sure. Last thing I want to point out here. Shrier's first Ormel reference did not find any evidence that people were having distress incorrectly diagnosed as depression. Quote, after generations of increased intervention, that, and I think she means the increased levels of depression now, shouldn't be the case. More access to antibiotics should spell fewer deaths from infection, and more generally available therapy should spell less depression. This is the shooting fish in the barrel portion, apparently. There's so many things, I hardly know where to start. As we discussed, the sort of treatments we've been talking about won't change the incidence of depression. For the most part, those are going to happen when things get gnarly enough in a person's life. And it is wildly inappropriate to directly compare antibiotics and infection-related deaths with everything she's throwing in the treatment bin and depression. Although at least she's keeping the paradox to depression here. Foreshadowing. We have a pretty good handle on how infections and antibiotics work. As we talked about with the two possible pathways of depression, that is less the case over in psych land. Psych disorders tend to have some confluence of biological, psychological, and social causes. Imagine the difficulty we'd have in treating infections if it had this wide variety of things that could kick it off. And then needing to really tailor the treatment options to that person in order to stand a chance in working. Now, throw in that some people will just have that one infection and be fine the rest of their lives, while others will be much more likely to have future infections now that they've had that one. A substantially more difficult proposition, no? Yes, Shrier, psychological disorders are a messier thing to deal with than an infection. That doesn't mean that the available treatments have zero effect for everyone. Note, she's switched from the previous umbrella discussion of treatment, encompassing therapy, medication, and social welfare programs, to just therapy. This narrowing of focus is a problem in the greater context of the case she's been trying to build, but also because of her citation there. And Note 29 has Shrier's thoughts about the 2010 book, Anatomy of an Epidemic, Magic Bullets, Psychiatric Drugs, and the Astonishing Rise of Mental Illness in America, by the investigative journalist Robert Whitaker. Yep, he's written about some science stuff, but it seems shady to call him a science writer, thereby boosting his science chops and credibility. She's pulled him in to further strengthen her argument that the incidence rate of mental health problems should have dropped because of the increase in treatments. But that wasn't what this book was about. As per a review of this book, there's two main lines of reasoning. First, psychiatric drugs aren't effective, and worse, second, that they are iatrogenically causing or exacerbating psych disorders in people. The author of this review, a nursing professor, did some digging of their own. For the first point, that psychiatric meds aren't effective, they've settled on the same point we have, that psych meds can be effective for people with more severe or recurring depression, but won't really do anything for the one-offers. For the incredibly disturbing argument that psych meds are causing illness, they didn't find evidence to back up that claim, even in what Whitaker had cited, at least for depression. Other reviews highlighted the important questions this book raised, particularly on the importance of tracking long-term consequences in psych meds, but note that the evidence provided is insufficient, especially on his two main arguments as being the result of big psychiatry being in the pocket of big pharma. Emphatically, Whitaker is talking about psychiatric drugs, not therapy. And what's coming next? I regret ever having complained about being elbow deep in healthcare spending data. This next little chunk of the video is where we're going to be talking about suicide statistics, and if you don't want to be hearing these, I get it. I had to take a couple mental health breaks while working through some of these papers, so time code is on screen to skip to the next chapter, which will also happen with the YouTube chapter designation thing, and also kitten. It's the best antidepressant I have right now. It's my little kitten. So, quote, "Instead, adolescent mental health has been in steady decline since the 1950s. Between 1990 and 2007, before any teens had smartphones, the number of mentally ill children rose 35-fold. And while overdiagnosis or the expansion of definitions of mental illness may partially account for this rapid change, it is hard to dismiss or contextualize away the startling rise in teen suicide." Nested quote, "Between 1950 and 1988, the proportion of adolescents aged between 15 and 19 who killed themselves quadrupled," the New Yorker reported. "Mental illness became the leading cause of disability in children." And note 30 is a quote from a 2022 New Yorker piece by Andrew Solomon. It does indeed talk about the decline of mental health in youth since the 1950s, specifically in the context of suicide, because that's what this piece is focused on, the rise in suicide rates in kids. However, it does not provide any sort of idea where these statistics are coming from, at all. Unfortunately, I wasn't able to simply find something along the lines Solomon said here, about proportions or those specific age brackets or years. I did find a relatively helpful table from the CDC, so that's the data we're going to be working with. Here is along the x-axis in 10-year intervals up until 2015. Solomon talked about a change between 2012 and 2017. This is the closest I could get. The y-axis is the death rate per 100,000 population. The suicide rate for the youths did indeed quadruple between 1950 and 1990, as Solomon wrote. But then it dropped between 1990 and 2010 before rebounding. However, at least in this data, the rate did not seem to double for the under 10s in the closest approximation I can do to the year Solomon said. But it is possible that the death rate for only the 10 to 14-year-olds would be different than when including everyone under 15. I've also included the adults here because there's a lot of changing trends in this time frame. In the same period youth suicide rates were on the rise, it was also increasing for young adults, but drastically decreasing for the 45 to 64 crowd. A 2006 paper speculated that the drop for the adults could be due to an increasingly strong economy, improved health with age, and decreased substance use. They also put forward that the across-the-board drop between 1990 and 2000 could potentially be attributed to the rollout of selective serotonin reuptake inhibitor drugs for depression, the SSRIs. That said, the rates have generally been growing for all age groups since 2000. Why is the rate of suicide growing again, especially in youths? This is a complex issue. I think it's unreasonable to expect that there would be a single, clear-cut answer behind all of this. Also, I'm just throwing in my 2 cents here. The experts are still wrestling with this issue, and I'm not an expert other than just what lived experience I have. So, in the full mix of contributory factors, social media is likely in the mix. Our friend nets have never been wider and more global, but suicidality can be contagious within a friend group if they're made aware of other friends attempting or succeeding. This was discussed prior to social media, so this seems to be more just a facet of how we're wired, with social media fanning the flames. Bullying has never been easier and harder to ignore. Instead of just going to school and being bullied there, you can be made fun of by people around the world in your own home through your phone. And being bullied makes suicidal behavior more likely. Another potential issue flagged decades ago was the amount of time parents have to spend with their kids, and parents' workload certainly has not decreased since the 90s. Related to Shrier's point, there is a relationship between general mental health and suicidality. Mental health drops, risk of suicidal behaviors increases. The various whys can be a bit different in youths, particularly younger youths. In adolescence, mood disorders are the most common psych disorder for those who die by suicide. Younger than that, ADHD is actually at the forefront, suggesting that impulsivity at that age is a strong, important risk factor. In adolescence, intimate conflict, so boyfriend, girlfriend, partner trouble, is a strong precipitating factor, and problems with parents or friends is more significant for the younger kids. Trouble at school is a general problem for both groups. An issue here for Shrier is that this isn't distinctly a US problem with our purported big therapy industry. It's basically global, as are problems with economic and housing security and mental health care access, along with general declines in mental well-being. It's almost like the money being spent on treating depression and anxiety isn't able to actually get down to the root cause for many. It's like we're treating the symptoms, but not the underlying societal condition, as it were. That's basically the first sentence of this paragraph done. What's next? Endnotes 31 and 32 are to the Whitaker Anatomy of an Epidemic book, again from Endnote 29. That was the one about psychiatric meds inducing the myriad psych disorders instead of treating them. This does indeed contain the, quote, 35-fold increase claim, albeit not in the same context as Shrier's used it. Fuck's sake, Shrier. Whitaker specifies this is for, quote, the number of disabled mentally ill children, according to information from the Social Security Disability Recipient Reports. Shrier is using it more broadly, for all kids with some form of mental illness, federally recognized disabled or not. Bad therapy? More like bad journalism, right? Also, while we're here in this shot, we're going to skip entirely the discussion of the high hurdles associated with obtaining and maintaining any sort of non-retirement Social Security income. Nope. That is a huge issue that's largely outside of what we're talking about in this video, aside for a couple parts where it comes in. I know this is a huge problem. It also means that the numbers Whitaker's using are almost certainly underestimates for the population sizes. He has a plot of the, under the age of 65, number of recipients of Social Security Supplemental Security Income, or SSI, and Social Security Disability Insurance, SSDI, over the course of 20 years. SSI payments are based on need, so aren't dependent on how much you'd previously paid into Social Security. SSDI is based on payments into the system, which is also true for children who are linked to their parents' payments. In one of his endnotes, he explains that he did some almost napkin math to come up with the total, and that this data is coming from the annual statistical reports from the Social Security Administration. The numbers for youths are coming from a similar source. We're talking about this plot of Whitaker's because, honestly, the information he provided in his endnotes isn't enough for me to find what he's talking about, especially 15 years after this book was published. The data for this are not among the source documents shared on his websites. Having poked around them a bit, I'm not sure they ever would have been. I've tried to hunt down the data to replicate the figure so I can know I'm at the right source when he's talking about the youths. Tried and failed. Maybe if I lived in DC, I could walk my happy ass down to the physical archives and dig around in person, but alas, I live on the other side of the country, so I only have what I can find online. Their online records only go back so far, and for the older data, it's piecemeal summaries worked into newer reports. As such, I can only really check figures after 2000. Kinda. I think I've managed to find the 2002 and 2007 values for the plot, as well as the, quote, 561,569 children on the SSI disability rolls. Info for 1987? No such luck. However, there is something Whitaker hasn't included that has a pretty big piece of this puzzle. In the 90s, the SSI program for children with disabilities changed, and a slew of psychiatric disorders were added, including anxiety, eating disorders, autism, and ADHD. Even with the higher hoops parents would have to jump through, this winded up who would potentially qualify for this benefit. Said plainly, with that extra context, no fucking shit the number of kids with disabilities increased. If the definition is changed to include more people are going to be included. I really can't emphasize this enough. The definitions were changed in the 90s, which let more kids get access to SSI. Whitaker is hyping this up as a hugely dramatic rise that must be happening because we're medicating kids more, thereby giving them psychiatric problems, and not a documented change in how eligibility is calculated. There's something else we need to keep in mind here. In order for minors to be eligible for SSI payment, they still have to meet the low familial income criteria. As of checking today, the 2 parents disabled child monthly income cap is roughly under $5,000 a month, plus having less than $5,000 in resources, like bank accounts and vehicles. As I said, I haven't been able to find the specific data he uses before the year 2000. And I can't find comparable data until 2003. In that little window there, youth data weren't included. So, that leaves us with this plot. I would include more points, but the Social Security Administration seems to have only published data about kids receiving disability benefits for the handful of years I've got there. Seriously. While trying to hunt this info down, I found a report by a committee tasked with understanding the changes in mental health-related disability in youths. They are looking from roughly 2004 to 2013, and huge chunks of their data are credited as, quote, unpublished data set provided by the SSA. And unfortunate for this video, that report is looking at the data for 10 specific mental disability categories, so I can't just swap it in. So we are back to this plot. Yes, the rates have grown. And yes, these are only the children who were of sufficiently low familial income and met the truly disabling levels of disability required to receive these payments. Additional things to consider from that committee report. Impoverished living conditions exacerbate mental health problems, and more children live in poverty every year thanks to wage stagnation and the growing cost of living. The makeup of the most prominent disorders was, and quite probably still is, in flux. This is the report's plot of the top 10 major psych disorders between 2004 and 2013. The vertical axis has the number of recipients for each disorder. While ADHD and autism rose in that time period, kids receiving benefits for intellectual disabilities dropped. Things like mood or learning disorders grew slightly. Recall from the insurance spending part earlier that ADHD was the fastest growing condition across the board, so this trend is broader than just low-income children. One way to look at this then is that more people are being diagnosed and treated for ADHD. As I said earlier this series, this could reflect an equilibrium between two things. On the one side, there is the population prevalence of ADHD. In the days of corporal punishment and strict child obedience, people might have been more inclined to try to mask and stuff all of that ADHD-ness down and cope as best they could, probably at great personal expense. Now with less of that, people are able to be more themselves. Couple with that, greater understanding and awareness of what ADHD looks like, and more people are getting diagnosed and treated. Like, a good friend of mine was very recently diagnosed herself with ADHD, and she's my age. Well, 2 whole days older, but still. On the other side are the environmental aspects of our society. Increasingly, school and jobs are forcing ADHD people to function in tiny little boxes that are difficult for them, so treatment is much more a necessity for them to continue. In ye olden times, I'd hazard a guess that many people with ADHD probably were able to find work that didn't necessarily see a detriment from, maybe even a benefit from the hyperactivity. And in slower and simpler days, inattention was probably less of an issue. So the way I see it, this overall increase in mental health spending, seeming to be largely driven by increasing rates of ADHD, are like a byproduct of where we're at. If everyone wasn't being mentally pulled in 10 directions all day, every day while being physically tethered to a desk, people with less severe ADHD might be able to just raw dog life. I think Shrier biffed her referencing. Endnote 32 is Whitaker's book, no doubt, but she is clearly talking about the New Yorker piece about child not doing wellness from earlier. GG. Actually, having taken a step back to reread this paragraph, it's almost like it got shuffled. She's jumping back and forth between 2 points. Her editor should have caught this and had her fix it. Maybe the endnotes wouldn't have been scrambled then. However, she is correct that mental illness is the leading disability cause in youths. However, I wouldn't totally say this is necessarily as damning as she's making it seem. Don't get me wrong, psych disorders are no walk in the park, and the threshold for the government to consider you disabled is pretty high. So these kids who've met that criteria are having a super hard time. Most kids' bodies aren't falling apart from age, and they aren't doing the sorts of activities that tend to kick adults into being physically disabled, like construction work. The kids are mostly rocking what biology gave them, with some influence from the environment. So, if bio and the environment dealt them a harder psychological hand, that's going to be reflected in higher rates of psychological disability than adults who have been physically beat down for longer. Last couple things here. For the overdiagnosis Shrier slipped in, Her own reference for the treatment-prevalence paradox said there was no reason to suspect this is happening. Finally, as a note, it is inappropriate to apply statistics about the proportion or numbers of children on disability as a representative subsample of the general population. The committee report estimated that in many conditions, something like 1 to 20% of children potentially eligible for benefits are actually claiming them. Also, the report included that, at least with how Social Security billing and coding works, kids with ADHD have a high chance of having other comorbid psych disorders, but there isn't much point in including an exhaustive list of everything that's comorbid with the ADHD because it doesn't matter. You've got the ADHD secured, you don't need to exhaust the list with everything else and spend all the time getting those other things fully documented and diagnosed. So the rates of other disorders might be going up too, it's just they're masked by the primacy of ADHD. Quote, "Yes, the coincidence of these two trends, deteriorating mental health in an era of vastly expanded awareness, detection, diagnosis, and treatment of psychological disorders, may be just that, coincidence. It does not unveil a causal arrow, but it is peculiar. At the very least, it may provide a clue that many of the treatments and many of the helpers aren't actually helping. At best, she's just asking questions. At worst, she's flooring the gas on conspiratorial thinking about big therapy, and she's already revealed her hand towards the latter in this book. Also, she's managed to do a little bit of the Peterson problem here. If you don't think about this too deeply or critically, it would seem strange, at the very least, that the rise in all that stuff is happening alongside the slip in mental health quality. But as we've diligently gone through in this video, none of these pieces should be reduced down and treated this superficially. Let's go back to the treatment-prevalence paradox in its home context, depression. As we saw, that paradox might be because there's a couple different flavors of depression, and the full treatment is only appropriate for those who won't naturally bounce back from their relatively mild depressive episode. Only a subset, a minority, have the more severe depression that needs all of that extra treatment. We're nearing the end, so I want to share this comparison. I have bipolar, one of the mood disorders if you're not familiar. My first depressive episode hit when I was in my early teens, and I've gone in and out of depressive episodes since. My husband does not have a mood disorder, although he did have a depressive episode as a kid. Early into us dating, we were comparing stories about that, and he suggested that I try doing what he did when he had that depressive episode because it really helped him. He said this with the best of intentions, so, focus on the good, and that life is a gift worth living and enjoying. We were committed enough at this point that I knew he was coming from a good place in saying that he was trying to help me. So we had a bit of back and forth about this, and eventually he did see that this isn't something I could just fix like that. Like, it's not just going poof into being better through some nice thoughts. The literature about the 2+ flavors of depression reminded me of that and helped me recontextualize it. My husband is one resilient SOB. It takes a lot to shake him from his life's at least okay perspective. It's entirely possible he had that depressive episode and in it was able to develop and foster those coping skills that let him resolve it without intervention. At the same time, it's also true that I am a returning visitor to Depression Town. I've gotten better coping skills over time and learning how to recognize things and manage it, but sometimes depression brain is going to depressed. Like the past 2 weeks, as a matter of fact, I feel like it's been trying to kick off just a crash and emotional depression state because it's been antsy for it, I can tell you that. Just, hey, remember this shitty thing? Remember that thing you did? Remember this other thing? Like, turned up to 11. Smooth sailing so far, but it's been trying. So, comparison between the two of us, food for thought, at least. Quote, "Therapists will insist that I've got things wrong and up. They are the lifeguards, not the sharks. It's simply that the rising generation has been swimming in shark-infested water, meeting more formidable challenges than any prior generation." Shrier continues by talking about the work of Carla Vermeulen, who wrote Generation Disaster, Coming of Age Post 9/11, and how her point, paraphrased, is that the youths are getting hit with more shit faster than any prior generation. We will talk about that book and the author more in the following sections, so try to remember it for the next bad therapy video. On this front though, it seems laughably dumb to try and say we collectively aren't getting hit with what feels like exponentially increasing historical events and other major shit on a regular basis. I was born on the relatively early side of the 80s, but consider the 90s my childhood, really. The Berlin Wall came down and the Cold War thawed, and there were wars, but I only kinda saw them sometimes on the news. We met the challenges of lead in the gas before I was born, hole in the ozone layer, and acid rain. And as far as I was told by the media and stuff, racism and sexism were solved. Then Columbine happened while I was in high school, and 9/11 when I started undergrad. And it just feels like it's been ramping up steadily ever since. My point here, that I would think Shrier would also feel, at least on some level, since she is a young Gen X and I'm an elder millennial, is that when we were kids, things felt relatively calm and low-key. We didn't have to worry about mass shootings, especially at school. There were problems with the environment, but they felt fixable instead of the runaway train we're looking at now. There was the left-right political divide, but it wasn't the Jerry Springer situation it is now, with one side using the fascism fast pass. I could go on, but instead just, kids these days are having to deal with more shit than we did at that age. They haven't really had time to feel safe and okay their entire lives. That is going to have an effect on their sense of well-being. Final quote. Therapists are helping young people, they insist. Young people today simply face more formidable challenges than did their predecessors. Therapists typically point to 3: smartphones, COVID-19 lockdowns, and climate change. Guess where we'll be picking up next time. To close out this video, I want to reiterate the big takeaways. The general therapy and mental health field has grown since World War II. There's no reason to think that it has grown before demand, especially in the last 60 to 70 years. The amount we spend on mental health care is inadequate, especially when we compare relative spending with comparable countries. The treatment-prevalence paradox is still a bit of an open question, but could be due to there being 2 depression pathways with the one-offers and repeaters. And remember, the treatment-prevalence paradox is in the context of depression and to a lesser extent anxiety. It is about the treatment and prevalence of depression. That the prevalence of depression isn't going down despite there being more treatment of depression. Besides anxiety, kinda, I haven't seen the paradox used for the other psych disorders, like schizophrenia, autism, conversion disorder, whichever disorders, I haven't seen the paradox discussed. Shrier, using this paradox, is demonstrative that therapy bad is overextending what it is. And that's wrong. Especially because the largest growth in mental health spending has been in ADHD and autism, not parts of the treatment prevalence paradox. This is all a complicated mess, just like many people in a little funny bit of symmetry. Simple answers are likely incomplete, if not just outright wrong. Like Shrier's book. So I think that is all it needs to be said about the treatment prevalence paradox. So, till next time. Bye.